again, as Rajashri said, we're glad to have this topic for our refresher course. And we got the right person for today. So we had a tough time who can talk about palliative care in end-stage cardiac illness. I mean, that's a really big gap that we understand. In India, we couldn't find any who is confident enough to talk from their experience, not from the textbooks. So that's how I reached out to many sources and I got your contact through Ramya. Thank you so much for agreeing to be a part of this session, although it's during your working hours, I understand. Dr. Haider is a director, heart failure program at VA Boston Healthcare System, and he's associate physician, Brigham and Women's Hospital. He's also assistant professor of medicine in Harvard Medical School. And it is so heartwarming to see that he has a good history in writing for a lay audience, not just for healthcare professionals, which I understand is very, very important. And he has authored a few books, and I'm sure we'll make it a point that we'll go through these books. The three books: Modern Death and State of Heart, and The Song of Our Scars. It's very interesting to know that. And I emphasize the fact again that there is no such speciality or no such dialogues happening in the country in terms of end stage cardiac illness. And we are in palliative care for past 2 decades. We don't get referrals at all for patients with end stage cardiac illness. So that's something which is maybe we are looking forward to work with you to as much as possible to, if possible, to address those gaps in the country. Thank you so much for being with us for today's session. Over to you.
Thank you, Dr. Warrior, and it's great to be here. I'm based in Boston, where I'm currently in Philadelphia just while I was traveling, and it's great to be able to speak to all of you doing such wonderful work in India, taking care of patients at the end of life. I mean, this is really for me, just being able to speak to all of you. Is a real honor, because all of you are doing such vital work for the patients who really need help the most. And in some ways, I'm honestly not surprised that both actually, but well, I'll say that again. I guess I am surprised that even though, if you think about it, more people in South Asia are now dying of heart disease than any other place in the world. Heart disease, and you all know this because you're on the front lines. Heart disease affects South Asians at a higher rate than almost any other population. And at the end, regardless of how many advances we make for these patients with regards to treatments, the fact is that they will still end up passing away. And so the fact that in a country as vibrant and large as India, we don't have people who are experts in this is really telling. But that's also true for any other place. Even in the United States, where I am, the vast majority of training, the vast majority of referrals, the vast majority of care for palliative care centers around patients with cancer. And so what I wanted to do in this talk was I wanted to sort of share my own sort of journey and the journey of palliative care and heart failure and advanced heart disease in general. Share some tips that I think might be important, and then hopefully have time for discussion, because I think especially for this topic, I would love to sort of hear the specific issues that you all are dealing with, and so hopefully I can help with those and bring my own perspective. I have no disclosures. So, as Dr. Sridevi mentioned, in addition to being a researcher and clinician and a heart failure specialist, I'm also a writer. And a lot of my writing actually began focused around how people experience the end of life. And because when I was a medical student actually in Pakistan, and I graduated from Pakistan, and so my experience was very similar to the one that you guys probably all have. But when I came to the US, I found that how end of life care was treated in the US was very, very different from what I had seen. And so I really wanted to, so even though if you have a heart attack in India, you still get a stent or you still get medicines, or if you have pneumonia in India, you still get antibiotics, maybe you need a ventilator. But how people try to treat people at the end of life is very different in the United States, in part because of the fact that everyone has, that you can get life-sustaining treatment basically forever as long as the patient desires. And so that's where I started with my writing. That work has since been translated around the world in many different languages. I followed that up with a book on heart disease and really focused on how heart disease itself has changed. And a lot of that focus was also on how people experience heart disease, especially at the end of life. And then my most recent book was on chronic pain, which is something else that I'm sure that you all see all the time. And is something that we in the United States are also having to deal with, and it can be quite difficult. But before I wrote all these books, I wrote this article in the New York Times. It was called The Cancer of Optimism. And really, it was centered around a patient of mine who had a cardiomyopathy, who had heart failure. And she was not doing very well. She had very severe symptoms. And basically, there was a procedure that was advised for her, which I believed would be very, very beneficial. But when she ended up getting the procedure, she had a pretty fatal outcome and eventually actually died. And even though, bad things can happen after procedures, that's part of life and that's part of what we do. Where I felt I'd failed her was the fact that I hadn't prepared her for a bad outcome. My focus was so much on making sure that we just think about having positive thoughts, and we just think about the fact that she doesn't feel that she has hope. That I didn't prepare her for the fact that what if things don't go well? What if things go poorly? And I think that's really where I failed her, and that's part of what I would like to do. I think going forward is that how do we prepare patients not just for when things go well, but what about plan B? What if things don't go as we all hope they might? So let's focus a little bit on heart failure. So, if you think about the heart failure population in general, again, the epidemiology might be different in different places, but about 50% of patients have what's called heart failure with reduced ejection fraction. So just to sort of explain what that means for people who may not know. So, the ejection fraction is how hard the heart squeezes. So basically how much the left ventricle squeezes. And in a lot of patients with heart failure, that squeeze becomes impaired. So instead of doing this like vigorously, the heart now does this. It's not pumping a lot of blood forward. This happens a lot after people have had heart attacks, etc. They go on to develop heart failure with reduced ejection fraction. My guess is that in India you probably see more patients with HFrEF, as we call it, than HFpEF. And HFpEF is the other condition in which the heart failure, the pumping function is normal, but the heart becomes very stiff. So even though the heart looks fine when you take the pictures, the pressure in the heart is high because the heart has become quite stiff. And the symptoms that people have from HFrEF and HFpEF are very similar. Um, Notice that there's a small yellow line right in the middle. And these are patients who might get heart transplant or mechanical pumps called LVADs. Um, Other than that, most of these patients, the vast majority of patients who develop heart failure will not have any type of therapy that is going to cure their heart failure. Most of these patients who have heart failure would live with heart failure and eventually, unfortunately, die with heart failure as well. So it's really important to think about what type of palliative care do we have for these patients, especially as they get older and they approach the end of life. The other thing that we've seen here in the United States, and also this is true worldwide as well, is that the prevalence of heart failure is increasing. And part of the reason why more people have heart failure now than they've had before is because our treatments for the acute cardiac conditions have gotten better. So if you look at treatments, for example, for heart attacks, heart attack treatments have gotten much better than today than they were, 20, 30, 40 years ago, when basically if you had a heart attack, you essentially died. And now, because of improvements in treatments for heart attacks or myocardial infarctions, what we now see is that a lot more people survive that initial event, but then they go on and live with heart failure and develop heart failure, oftentimes at very old age. So oftentimes many of our patients will have heart failure, but they'll also have a geriatric syndrome. They'll be frail, they'll be weak, they'll be deconditioned along with their diagnosis. So heart failure is a condition that for most patients we don't really have a cure for, and the prevalence is increasing, and it's increasing around the world. And in fact, it is much more concentrated amongst people who are older, amongst older individuals. So then the question is, well, how effective is palliative care for patients with heart failure? What is the evidence for palliative care in patients with heart failure? And so the fact is that, like I mentioned at the start of this presentation, that the vast majority of palliative care research, the vast majority of palliative care clinical care is provided for patients who have cancers. But the fact is that after cancer, probably the best evidence base for palliative care actually exists for patients with heart failure. So now this is a summary of major clinical trials that have been performed that look at that used and these are all randomized trials. So this is very high quality evidence, which used palliative care at different and in different sort of ways and in different settings. So there was a trial that used inpatient palliative care. There was an outpatient palliative care trial, home-based palliative care, and telemedicine. And as you can see, is that directionally, most of these, all of these trials did seem to improve quality of life. They did seem to improve patients' symptoms, and they also seemed to improve how people felt. The thing that we did in addition, this was a meta-analysis that we published. We pooled all these research together. And what we showed was that palliative care is very effective in patients with heart failure in reducing also hospital admissions, and also in improving advanced care planning. So making sure that whether patients are getting the sort of care that they would have wanted, that they would have preferred, instead of getting care that they may not have wanted. And it's actually because of all of this, and there's other benefits too that we have seen with palliative care used in patients with heart failure. Palliative care allows more patients to die at home, and the earlier that we involve palliative care, the more likely they are to die at home. Palliative care reduces the number of patients who are spending their last few days in the hospital and the ICU, and also importantly, palliative care increases how one of the challenges that we have in heart failure is that patients may underestimate and physicians may underestimate the prognosis. What that means is that they may not think of heart failure as a lethal illness the same way that they might think of, for example, cancer. So if someone has cancer, they feel like they're going to die. For a lot of our patients with heart failure, and this is what we struggle with here, and I'd love to know what you all experience, is that even though they have heart failure, they don't take it as seriously as they might take another more serious condition. And palliative care reduces that gap in prognostic estimation. So it helps them take the disease more seriously as well, which is very important when it comes to accepting palliative care and potentially hospice. And it is because of all of this evidence that the American College of Cardiology and the American Heart Association, which are the two major cardiology organizations, both in the United States but also internationally, actually give a class 1 recommendation, which is their highest recommendation, for the use of palliative and supportive care in essentially all patients with heart failure to help improve quality of life, to improve how they think of their prognosis, to clarify goals of care, to facilitate shared decision making, and to allow for better symptom management for all patients with heart failure. And then specifically, it also recommends extensive use of palliative care for patients as they approach the end of life and when they're facing hard decisions regards to life-sustaining care. And then there are other sort of settings in which they also recommend palliative care. They recommend hospice for patients who have expected survival of less than 6 months. They recommend palliative care for any patient who is considering any type of major surgery, such as a heart transplantation or a heart bypass surgery or anything else like that. Just knowing how important that palliative care can be in that decision making. But at the same time, as I've shared with you, that the data for palliative care in heart failure is very strong. The guidelines very strongly support palliative care. At the same time, referrals for palliative care, both in the United States, also remained quite low. This was a registry analysis that we did that was a US-based registry, in which we showed that even though over time the number of referrals for palliative care coming from medicine and critical care have gone up, the number of, or the proportion of referrals that are coming from cardiology have actually gone down over time, suggesting that even in the United States, when it comes to palliative care, our field in cardiology is still lagging behind other fields in making sure that are we referring patients to palliative care in a timely fashion. So what I wanted to do today was I wanted to sort of think about some clinical tips that I could share through my work, and then hopefully at the end we'll have some questions in which we can also address some additional questions that you might have. So I think the first thing that I wanted to share, I think this is probably one of the biggest challenges that we face in patients with heart disease, especially at the end of life, is that prognosis can be very unpredictable. It can be very hard to tell which patient is going to die and which patient is not. And in fact, when we've looked at studies comparing prognosis or estimation of prognosis amongst physicians for example, cancer versus heart failure, what we've shown is that physicians are much less accurate when it comes to predicting prognosis for heart failure as opposed to cancer. And in fact, this type of difficulty in prognostication is also faced by patients and their caregivers. So this is another US-based study in which after patients had died, their caregivers were surveyed. And one of the questions that the caregivers were asked was whether those deaths were unexpected or expected. So the first thing that they did was that they talked to patients who had cancer, and only 18% of caregivers of patients with cancer thought that their loved one's death was unexpected. But when they looked at heart failure, that percentage was 50%. So what that shows you is that even though these patients were dying of heart failure, most of the times those deaths were considered unexpected, and so patients didn't even realize how sick these patients were, and their caregivers did too. And if patients and caregivers don't feel like a disease is very serious, they're not going to make the serious decisions that are needed for these patients at the end of life. And in fact, one of the things that has been done to try to overcome this and to be better at estimating prognosis is by using some risk scores. And these risk scores are not actually very sensitive, as you can see in these data here. But one of the things that can be very important is actually clinical intuition. So as you can see here, these are two curves. And the difference between these two curves is that the clinicians who were taking care of these patients were asked the surprise question. But what is the surprise question? The surprise question is that would you be surprised if the patient passed away within the next year? And if your answer is yes, so for example, like if I ask any of the members in this group, if they have a patient with heart failure, would you be surprised if this patient died within the next year? And you say that I would not be surprised, then the chances of that patient dying in the next year is actually very, very high. And so clinical intuition is actually very useful in patients with heart failure, and in fact, exceeds that of traditional risk scores. And that's not just the clinical intuition of the cardiologist, but in fact, the nurse as well is also has very high sensitivity in looking for patients or assessing the risk of patients. So, often what I say is that trust your guts, trust your instincts, and if you're worried about a patient, you're probably right. You're probably if you think that a patient has a very high chance of dying within the next year, your intuition is probably correct, even though it can be challenging to assess prognosis. So that's tip number one. The tip number two, which I share a lot with cardiologists, is that really about the need for having thoughtful discussions around major medical decisions. Now, the fact is that a patient with heart failure can live with heart failure for a long period of time. It used to be that heart failure, once you developed heart failure, died within a few months, but now you can live for many years with heart failure. And over those years, there can be many big turning points or many critical times to make the key decisions. Patients may have worsening heart failure leading to hospitalization. They may need to have a discussion about a procedure, such as a defibrillator or a pacemaker, or any other type of surgery, or they might need to be placed on palliative inotropes. And so all of these moments are actually important cues in which we need to be having important discussions about making sure that what is patients' understanding of their illness and what is the sort of care that they would like to receive going forward. And I think that we miss a lot of these opportunities. And again, many of these may happen before patients come to you. You know, they may be happening in cardiology clinics, etc. But a lot of patients are getting procedures and tests without actually having a sense for what they will actually do. One of the resources that I think are quite useful for patients who have heart disease has a website called patientdecisionaid.org. Patientdecisionaid.org. This is developed by the University of Colorado, and what they provide is that they provide a lot of different both video decision aids, but also printed decision aids to help patients who are considering cardiac procedures, cardiac surgeries, or medications, and even hospice. And in fact, if you look at the list of things that they have decision aids for, they have, for heart, for AFib, for defibrillators, for pacemakers. So I think that this can be a good resource for you all if you're having to help patients make these decisions so that they can better understand what's going on. And I'm happy to connect you with the people who run these in case you want to get them translated for some of your local patients as well. So, one of the questions that comes up all the time in clinical care is, well, what is the right time for palliative care for patients with heart disease? Um, and the answer to that is really that it's earlier than you think. So no matter if you are thinking about palliative care for a patient with heart disease or heart failure, not only is the right time, but you're probably already late. Whenever people feel hesitant about whether the patient needs palliative care or not, I tell them that no, you shouldn't be hesitant, because what the data suggests is that every time we do call palliative care, we're often quite late. And so one of the ways that we looked at it was again through this national registry that was based in the United States. And what we found was that if you compare patients with heart disease versus patients who have cancer who are referred for palliative care, this is not a hospice population, this is a palliative care population, we found that about 30% of patients with cardiac disease are bedbound at the time of initial referral for palliative care, compared to only about 19% of patients with cancer. And so these patients also, because they are so functionally impaired, are also much more likely to die sooner. So again, these data suggest that we wait a long time before we think about palliative care for patients with heart disease versus patients with cancer. And in fact, if you look at the average age at the time of referral for palliative care, at least in the United States, the average age of the patient with cancer is 68, while the average age of the patient with cardiovascular disease is 78. Now, this might be actually lower in places like India or Pakistan or South Asia in general, where people are much more likely to have premature cardiac disease. But still, again, what it shows is that oftentimes, even though we don't refer a lot of patients with cardiac disease to palliative care, even when we do, we often do it late. And for me, the goal of sort of true or ideal palliative care is that, as a patient has this journey with heart failure, starting with this initial period where they're diagnosed, they might get treated, and then they might get better for a long time, and then they have this terminal phase at the end, that we introduce palliative care gradually through the patient's course rather than only at the end. Because once you only introduce palliative care at the end of a patient's course, they might be much more likely to feel like they don't that's not something that they want, that they may feel that they're being abandoned by their physicians. And so there can be a lot of hesitancy in accepting palliative care if you only refer patients right at the end. And so for me, the goal is that how can you introduce concepts of palliative care throughout the patient's life history, starting from initial diagnosis through their chronic stable heart failure phase, and then much more so in their sort of end stage terminal phase. With regards to referral criteria, so the question might be, well, who do we refer for for palliative care? And there's two different ways to look at it. So one way you might look at it is by looking at what is the patient's needs. So you can look at their physical or emotional symptoms. You may look at functional decline. You may think about whether they need help to make important decisions, or if there's caregiver distress, etc. The other way that you could think about referral criteria is that you could look at the sort of specific disease itself and look at what is the stage of the disease. Does the patient have symptoms of heart failure even when they're at rest, for example, which would be class 4? Are they needing to go to the hospital or emergency room all the time? Do they have poor prognosis based on the surprise question? Do they have uh, significant comorbidities? If you ask me, in my experience, I mean, the things that make me worry a lot for patients with heart failure, one is cardiac cachexia. What that means is that, a lot of times patients with heart failure gain weight because they're filling up with fluid. But it's when they start losing weight, when they start losing muscle mass, that I start to get very worried about patients' heart failure. So you all probably see a lot of patients with cancer who have a lot of cachexia. They're very weak, they're very malnourished. And when a patient with heart failure starts to look like that, I become very worried because that is certainly a sign that they may have very advanced disease. The other thing that makes me worried a lot is low blood pressures. So a lot of times patients with heart failure have high blood pressure initially, but over time their blood pressure might drop. And that can also be suggestion that the heart failure is becoming progressive. Also, end organ dysfunction. So thinking about if patients with heart failure have other organs becoming involved, like for example, if they develop kidney failure, if they develop liver failure, if they develop pulmonary hypertension or other sorts of other end organ dysfunction, that makes me worried quite a bit that they're reaching the last phase. But for me, as far as a good referral criteria for palliative care is concerned for patient heart disease, I think the broader the criteria, the better it is, because honestly, we're not being the problem in palliative care is not that being over selective. The problem is that we're just not getting enough referrals. So having a broad referral criteria is, I think, the best to provide early access to palliative care for patients with heart failure. So, one of the things that, especially in cardiology, I think that we miss is that, oftentimes when we think of heart disease or heart failure, we often think about just patient having chest pain or having difficult breathing. But the fact of the matter is that patients with heart failure can have many, many symptoms in addition to having shortness of breath. So, and this is something that you all probably know better because you see these patients at the end of life. But, when we've looked at studies, we've shown that shortness of breath or dyspnea, as we call it, is only a few patients that patients will have many many other symptoms in addition to their dyspnea. And so it isn't just a matter of whether that they have this one symptom. And I think that's another reason why palliative care is so important, because as a cardiologist, maybe I'm good at treating their shortness of breath, but I might not be good at treating their anxiety or treating their depression or treating their constipation or treating any of the other many, many other symptoms that these patients have. And when we've talked to hospice nurses here in the US and have asked about what are the patient symptoms that they find most challenging, a lot of our the nurses here struggle with ascites, they struggle with depression, they struggle with confusion that their patients experience, or fatigue. And so just simply focusing on dyspnea and shortness of breath or chest pain as being the main symptom to treat in these patients, what that does is that it ignores the fact that these patients can have many, many other symptoms in addition to that. So another tip is many heart failure therapies improve symptoms and quality of life, not just survival. So I think traditionally, when we think about, for example, chemotherapy for patients with cancer, we know that for many patients, chemotherapy it might help them live longer. Maybe it doesn't help them live too much longer, but it can increase their survival. But oftentimes, that chemotherapy also makes them feel really bad. Their quality of life may actually go down. But in heart failure, the benefit is that the traditional medical therapies that we have for patients with heart failure, like pills like ACE inhibitors or beta blockers or spironolactone or all these other new therapies that are now becoming widely available, not only do they help people live longer, but they also help quality of life, they help their symptoms, they help their symptom burden. And so, oftentimes when we think about cancer therapy and palliative care, oftentimes they can be mutually exclusive, or the cancer therapy might not actually help the patient feel better, while the palliative care physician is focused more on symptom burden and quality of life. And I think the fact is that in heart failure, conventional heart failure care and palliative care, there's a lot more overlap, because one of the first thing I'll ask, or any cardiologist will ask any patient heart failure, is how do you feel? the first thing that we ask is in fact directed towards their symptoms, and most of our therapies do improve symptoms as well. So I think that provides, so one of the things I would suggest is that even if you have a heart failure patient who is quite sick, you know, they may actually benefit from staying on some of their heart failure drugs if they can tolerate them based on their blood pressure, etc., because not only might that provide some type of survival benefit, although that might be limited in a more sort of end stage patient, but it certainly might help them feel better and improve their quality of life, which is different from how we think about sort of conventional chemotherapy, for example. So I would love to learn more about, you know, how you all use inotropes, which are these IV medications that patients with heart failure may get. This is a recurring issue that comes up here in the US, so I'm going to talk a little bit about them. But basically, there are these IV medications called inotropes, like milrinone or dobutamine, that, you know, many patients with heart failure at the end may receive. And some people, even though we don't have clinical studies, a lot of physicians and patients might believe that this might help them feel better. But the fact is that they actually shorten survival. But these inotropes can come with a lot of risks, both related to the IV line that the patient might have, but also from the medication themselves. And really making sure, I think for my emphasis is always making sure that we're selecting the right patient for these treatments, because they can actually be very burdensome for patients, because having an IV at home running continuously can be quite burdensome. I mean, we can discuss more at the end if this is a recurring issue, but I feel that most patients with heart failure actually don't need these therapies. And of the two therapies that we have milrinone and dobutamine. Both of the medications are actually fairly similar. Milrinone is a bit better in patients who have normal kidney function, and dobutamine is better for patients who don't have normal kidney function. So let's talk a little bit about hospice, and I'd love to learn more about how hospice is different in India compared to the US. Most hospice in the US is delivered at home, and is meant for patients with an expected survival of 6 months. Some hospice facilities also exist, but they're pretty few in general. The vast majority of hospice is provided in people's home. And when it comes to heart disease, hospice is both underused and poorly used. So if you look at the number of people who are dying of heart disease in the United States, 23% or maybe a quarter of patients of total people in the US die of heart disease. But if you look at the number of people in hospice, only 6% of those are dying of heart disease, so showing that many more patients are dying of heart disease without receiving hospice care than other conditions. And in fact, if you look at all the major medical conditions in the United States, from cancer to stroke to Alzheimer's, patients dying of heart disease actually have the smallest proportion of patients dying in hospice. So really, very few patients with cardiovascular disease, even in the United States, are actually dying in hospice. So that remains an ongoing issue here. But the point is, even when we decide that someone would be an appropriate candidate for hospice, we often make that decision very late and actually set them up to fail hospice. So this was, again, data from another study that looked at people in the hospital in the United States who were being discharged to home, and who were being discharged to hospice, and tried to identify what the characteristics of those patients were. And so one of the things that we found was that about 35% of patients who were in the hospital and discharged to hospice were discharged with unchanged or worsening symptoms. Now, if you look at all patients with hospice, that proportion is only 1%. So again, if you imagine that if a hospice is getting a patient who has worsening symptoms, even though they've been in the hospital, which is where they can receive the most intensive treatment for heart failure, how are they going to do better in hospice? How are they going to have their symptoms controlled in hospice? We really set them up to fail. The other thing is that the average survival of patients with heart failure discharged to hospice is only 11 days. And so even though hospice is meant for patients with an expected survival of 6 months, most patients actually die much sooner. And in fact, about a quarter of patients who die in hospice die within the first 48 to 72 hours. So even though we send very few patients with hospice, with heart disease to hospice, even when we do, many of them are actually quite sick and die very soon. So they're unlikely to actually even experience the benefit of being in hospice because we made that decision so late. And then, so that is one teaching point that I think is important, especially early on, is that we really need to be thinking of hospice sooner in these patients, and that we need to be prepared for the fact on your end that a patient with heart failure coming in might actually be quite sick and may die pretty soon. So one of the things that I mentioned at the start was about ejection fraction, and which becomes a very sort of key metric or key data point when we're evaluating patients with heart failure. Everyone asks, well, what's the ejection fraction? What's the ejection fraction? But the fact is that at least in older patients with heart failure, ejection fraction actually does not predict survival. In fact, the average person who has heart failure, the average older person greater than 65 years of age who has heart failure and is in the hospital in the United States, lives on average of 2 years, which is a similar survival to many cancers. And that 2 years does not change based on whether the patient's ejection fraction is low or high. So ejection fraction is actually not very prognostic. It's all these other factors related to a patient that are much more suggestive of whether they have, of how long they might have to live. And in fact, we've shown that patients who have HFpEF, patients who have normal ejection fraction, are even less likely to receive a timely referral to palliative care than patients with low ejection fraction. And then one other thing that we're seeing, at least here in the United States, is that, for a lot of patients, a lot of our patients want to die at home, but home may not be the right place for many patients. So what we've shown in our previous work is that now, for the first time in modern history, more Americans die at home than they do in the hospital or in a nursing home. And yet, what we're seeing is that of all these patients with heart disease are actually least likely to die at home. And in fact, some of our racial and ethnic minorities and patients who are poor are even less likely to die at home than others. But the fact is that for many of our patients, they may be so symptomatic that it may be better for them to actually pass away in a hospital or in a hospice facility than at home. Many of our patients with heart disease can have a lot of limitations with activities. They might be very frail. They may have difficulty walking, with eating, getting in and out of bed, etc. So they can be quite debilitated. So again, another reason why it's really important that they have adequate caregiver support as well. And then the last thing I want to focus on is that, oftentimes when our patients have heart failure, it's actually part of a much bigger puzzle. On average, the patient with heart disease has between 6 to 7 other conditions that they have in addition to their heart failure. And we see that they can have very significant physical impairments. A quarter of patients, even when they're optimized in the hospital, are unable to stand from a chair. A third can't perform a tandem stance. And about a third meet criteria for frailty. Many patients, 4 out of 5 patients with heart failure, have cognitive impairment. So, they may have difficulty remembering things. A lot of patients have unrecognized depression connected to their illness, and a third of our patients live alone. And then the other need really is that with regards to making sure that we have a good bond and good relationship between heart failure and palliative care, we also need a strong relationship with geriatrics, because a lot of our patients will have a geriatric syndrome when they have advanced heart disease. And one of the other things that we're noticing here in the United States, and this is probably true in India as well, that a lot of our patients also have additional financial burden that causes them to have even more, and that financial burden can actually add another layer of complication in addition to their illness. So just to round off, heart failure is an increasingly common condition, has a rising mortality rate, is associated with widespread physical and quality of life impairments, is a chronic, progressive, incurable condition with limited life expectancy, with a crushing burden of symptoms and healthcare resource use, and therefore is actually a perfect condition for palliative care. And so the fact that we continue to underuse palliative care in heart failure is really a travesty. And the tips that I kind of went over, and there's more that might come up in the discussion, include that prognosis is unpredictable in heart failure, but that the surprise question might help you. It's important to have thoughtful discussions around major medical decisions. The right time for palliative care is earlier than you think, so that's what I tell most of our clinicians. Heart failure patients have burdensome symptoms beyond simply shortness of breath. Many heart failure therapies, medical therapies, pills, actually improve symptoms and quality of life, not just survival. So the patients, even at the end stage, might benefit from remaining on these therapies. Some patients may benefit from palliative inotropes, but they're a small proportion. Hospice is both underused and poorly used in heart failure. Ejection fraction does not predict survival in older heart failure patients. Home may not be the right place to die for some patients with advanced heart disease. And oftentimes, heart failure is just one piece of a much bigger puzzle that these patients experience. So, I've been advocating for a long time for patients with heart failure to be able to have good, high quality palliative and hospice care. But as you know, that the work still remains. And that's part of the reason why I was very excited and honored to have been invited here to speak to all of you for doing all the great work that you're doing in India. So kudos to you. I'll stop my presentation here, and I'm happy to take any questions. Thank you.
Thank you, Dr. Haider, for taking us through a wonderful lecture. A lot of learning points in terms of referral, time for referral. And specifically, for me, it was beyond dyspnea. We always think of dyspnea when it comes to heart failure. I mean, yes, we do see anxiety or pain or inability to perform activities of daily living. But I think whenever we talk about cardiac failure, we think about dyspnea on the first hand. So, yeah, I think it's high time that we ourselves move out of dyspnea and start thinking beyond that in some terms of symptom management. Um, I would like the participants, if you have any queries, please unmute yourself and ask, or you can type it in the chat so that we can take up the questions for discussion. So while they are typing, yeah, there are a lot of questions for you, Dr. Haider. Will you be able to read it, or should I? They're asking for
Is there any role
morphine
for
and
morphine
midazolam.
and midazolam in cardiac failure? So that's an excellent question, actually. Yeah, absolutely, you can give morphine to a patient with heart failure dyspnea, for sure. I mean, especially if they're receiving palliative care and hospice care, there's absolutely no contraindication to giving morphine to a patient with dyspnea at all. So you can, I mean, again, it may, if there's other things that can be done, I think that we should explore other possibilities. Like, for example, diuretics can be fairly easy to give even in a hospice setting to patients who have heart failure. So I think that if a patient is volume overloaded, so they have fluid in their lungs or fluid in their legs or their belly, I think we should also try and treat that if possible. Again, it can be hard for a lot of patients to make the extra urine when they have advanced heart disease and they're receiving palliative care. But my sense is that yes, we should and we should give morphine to patients, especially end-stage patients who are in hospice, to help their dyspnea. But we should also think about maybe also giving them some diuretics as well, in addition, and not just using opioids only or morphine alone for dyspnea. With regards to midazolam, again, I think it depends on the context. So if the context is that you have a patient who is in hospice, who is terminally ill and has heart failure, then we should just treat their symptoms. And if they have anxiety and if they're feeling distress, which many patients will, because they can be quite symptomatic and they are afraid of dying, then we should just treat their symptoms as we would any other patient, and that can include morphine, that can include midazolam, that may include medicines for nausea, etc. So there's no restriction in these patients for the use of these medications, especially when they are at the end of life.
Thank you so much. While
Hello,
we are
sir.
waiting for other questions, yeah.
Hello. I am actually working Jharkhand and I get lots of heart failure cases. And most of the time, certain patients complaints of epigastric discomfort and jaundice, and so they don't recognize that it's a heart failure. They think of they are having jaundice, and they go to multiple doctors, end up with us. And certain patients come with hemoptysis, and they say we are having TB. Ultimately, diagnosis is the heart failure, and we find it very difficult to explain to them. And at we spend time to explain to them it is not that you're having TB, it is heart failure, or it is not jaundice. They keep on taking so many medicines, local medications for jaundice. And in my experience, I have found since this is a tribal area, lack of proper treatment for TB, they come with cold pulmonary, and the both lungs are severely affected. And such kind of patients, we explain to them, but there are also the young patients comes to me. Like last 1 year, I think I lost 4 patients. One was like rheumatic heart disease, heart failure. She actually had followed up to the last 4 years. And then in between, she had a thrombotic embolism and paralysis, recovered. Then she was sent home, and at home, she had a sudden death. Another patient was followed 1 month actually, young patient, 24 years. This girl was 16 years. Other patient was like 24 years with a severe fibrosis of the lung and heart failure. And symptomatically, she was okay when she was discharged, and she was brought dead to the hospital. And another young girl of 22 years with restrictive pericardial effusion. I tried to refer to higher center for at least to have symptomatic relief for the pericardial tap, but then they refused to go. Even that I lost. What I find with this young cases, elderly with the cold pulmonary, all that is easy to explain to them. And a young patient, I still struggle to tell them, see, to the patient attenders, we are able to explain to what is happening, how long will be their lifespan, all that. But these young children, I am really struggling to explain to them, you are at the end of your life. So I don't know how to go with it. They are young patients with heart failure.
Thank you, Mary, for sharing these stories, and they're really heartbreaking. They're really heartbreaking, and many of these instances you feel like I totally understand what you're saying. There's one thing that you have heart disease and you're 75 or 80 years old, and then you have advanced heart disease and you're in their 20s or 30s or 40s, and so I think in young patients in general, I think we struggle with anyways, right? I mean, if a young patient, no matter what they have, if they have a critical illness that is going to lead to their death, I think it causes a lot of distress. And I think we struggle with being honest with them, but also making sure that they still have hope, right? I think that's a real hard thing, because especially for a young person, you don't want to take away their sense of hope or optimism. And I know that many people, especially in our part of the world, they don't want to hear bad news. If they have a poor prognosis, they may not want to hear it, because they might feel, or their caregivers or family members may not want them to know about it as well. So I I think that what we can do for these patients is exactly what you're already doing for them. I think the fact that you're part of their life, that you're part of their care team, and that you is a real gift for these patients, because even if you don't realize it, you are providing them comfort, and you're focused on their quality of life, and you're focused on their personhood in a way that maybe other physicians might not be. Other physicians might be looking at, oh, what is their echo show, or what does their EKG show, and all we can do, the way I think about these instances, or these difficult cases, is that we cannot control the outcome as physicians all the time, or nurses all the time. Sometimes bad things happen despite our best efforts. But what we can control is the process. And the process for people in palliative care and people in medicine should be, Did I provide the patient the best information? Did I provide the patient comfort? Did I provide them a person that they could share their worries and hopes with? Did I improve their symptoms? And was I present for them in a really full way? That is the only thing we can control. We cannot control the fact that there's a lot of inequity in this world. We cannot control the fact that a lot of our patients, especially people who are coming in from tribal areas or people who don't have access, they're dying of preventable causes. We can't fix all of those things, but all I will say is that the only thing that we can control there is that we can control how we do what we're supposed to do. And so the fact that you were there for these patients when they're sick, the fact that you still remember them today, by all their details, and it affects you, what that tells me is that you did all that you could to be present for those patients and provide them comfort. So that's how I would respond to that, is that I want to thank you for sharing those, and those are the stories why all of us do what we do, because we want to help patients, especially when they're sickest. But we cannot always control the outcome, but what we can control is the process. There are a couple of other questions that I'm seeing. One is, sometimes we use diuretics plus inotropes for shock or hypotension. Is it a good idea for treating a heart failure patient? Yes, I think it is a good idea in the right circumstance to treat patients with inotropes or diuretics if it's appropriate. Certainly, sometimes diuretics can be more effective when they're used with an inotrope, but not always. Another question: in general, there's a kind of myth that only a cardiologist will be an outpatient doctor to treat patients with heart failure. Well, that is true, and I think that we see that in most places. Even here, where I think we have a lot of resources. The fact of the matter is, that when a patient has advanced heart failure, a lot of the other physicians will just kind of back off and just let the heart failure person take care or take charge of their illness. I think that's okay. But I think that type of over reliance exists anywhere, and part of that is because these patients are very complicated, and that a lot of times, primary care physicians or family physicians may feel like the illness is kind of outside the scope of their practice. So I don't blame them, just because I think that this is a heart disease. But I do think that the fix for this is better collaborative care between cardiology and other specialties. I think what to me what that shows is that I think that represents opportunities for cardiology and primary care or internal medicine or family medicine to collaborate better, because I think for many cardiologists, they would like some of that burden to be taken off. They don't want to be the primary care physicians for these patients because they can be quite complicated. This last one is more of a comment. Working as a medical specialist in a periphery, that too in a district hospital, we have to act as a super specialty doctor most of the time. I think that is appropriate. I think that these patients do benefit from having specialists taking care of them, just because they can be sick. But many of their issues and many of their are things that I think that others can deal with as well. But these patients are complicated, and many. And they can be scary to other clinicians because they feel like they might be outside the scope of their work and practice. So I'm sympathetic to that.
Dr. Haider, I was wondering, is there any practice like where you run combined clinics for patients with heart failure, where the cardiologist will be there, the palliative care doctor will be there, and having those conversations together with those patients? Are there any models that exist?
Yes, those models they're very rare, but they do exist. We have, and those models can kind of span both the inpatient side and the outpatient side. Right now, most collaborative palliative care programs exist on the inpatient side, where we might have a team. So, for example, at Brigham and Women's, we have a heart pal team, which is a heart palliative care team, which focuses only on patients with cardiac disease. And that type of model can work in a large hospital where you have enough patients and you have a big volume, so that you can support that type of team. We've also started a new outpatient palliative care clinic. One of the first things that we were doing was we had a remote virtual clinic for palliative care for patients with heart failure, but I didn't feel like that was becoming very effective, because I think a lot of the benefit of palliative care can be just their presence. Just the fact that you have a palliative care physician in your clinic makes you think about palliative care, and makes you think about sending referrals that you may not if it's just like a virtual referral you're sending elsewhere. So we are trialing that. I think a lot of the but the outpatient space is really where the big gap is. There's a big gap, and there's very few programs that have these types of outpatient programs. Even when they do, they're often funded through philanthropy and don't have a long-term funding mechanism. So even when programs are started, they're not long-term programs. They get phased out pretty quickly.
And while you work in this field for so many years, what do you think can be the barrier for referral to palliative care? Is it because that they think that the patients are not dying or going to
Yeah.
live and focus on diagnosis, or just that it is a barrier that they don't know how to communicate about the prognosis to the patient, so they just keep
Yeah.
going like that?
I think that there's I think it's a great question. I think there are two barriers. One is there is a clear cultural barrier where I think cardiology as a specialty is still a very much do everything specialty. Patient comes in with chest pain, they'll get their 30th stent, right? Or they'll get X medication. They've been in the hospital 10 times, they'll admit them the 11th time. And because there's this sense that that's what we do. This was, how oncology was for a long time, but over time, oncology has evolved and changed for the better. But I think culturally in cardiology, we're still behind, and a lot of it is because, many of our cardiologists, when they trained, they didn't have palliative care. They don't have palliative care training. They don't think in that way, so they may not realize the value that palliative care can provide. The second thing is also a a knowledge gap, and the challenge is knowing when is a patient with heart disease, when is doing more not going to be helpful. And that can be hard because many of our patients, they may not have that type of uh, for example, like if you have a patient who has cancer and they're on chemotherapy and now they have metastatic disease despite chemotherapy. I mean, that might alert their team to the idea that, oh, this patient has this sort of inflection point where now they might not benefit from additional chemotherapy, or they might need more palliative care, or if a patient has failed second line treatment, for example. So I think in heart disease, oftentimes it can be hard to tell when a patient has reached that type of inflection point. Even patients who are quite sick, a lot of times we may not be able to get them fully better, but we can get them better somewhat. And I think that can be challenging. So I think that is one thing. The other is a training gap where, I think a lot of our patients who have a lot of our cardiologists just don't have training. They don't feel comfortable having these conversations. They're not, their communication skills might be good for discussing interventions, but they may not be good for discussing advanced care planning or goals of care or figuring out what matters most to a patient. And so there is both a cultural deficit in that I think our field in cardiology in general around the world, this is true everywhere, is very, very focused on doing more stuff, just more things, whether that's medicines or procedures or hospitalizations, etc. But at the same time, there's a big gap with regards to knowledge and training as well, where even where we just don't have great tools, or we don't have the great training to have these discussions when they're needed. And that's why many times they may not have these important conversations.
Yeah, I think also there is a responsibility from our side also as palliative care people to learn a little bit more about the trajectory, because it's so unpredictable most of the times, and we need to have that knowledge backup before we get full-fledged on to provide palliative care services to patients with heart. Thank you so much. Are there any other questions from the participants? Can't see any questions. Dr. Haider, it will be helpful if you can share some of those relevant articles because most of the time we don't have access to most of these journals. So that will be really, really helpful if we can share some of the relevant articles that you shared in today's presentation. Maybe that's something which will be helpful. We can circulate it among the participants and for our own academic purpose.
Perfect.
That
Yep,
will be
happy
so.
to do it.
Thank you so much. I'm so glad that we had you for this session because this was purely based on your experience and the data. And you made it very simple to understand and touched upon areas which I have not heard in many of the talks related to cardiology and palliative care. Thank you so much for being with us for last 1 hour and sharing your experience and knowledge. And we look forward to have more interaction or sessions or to work with you if that is something which you can give us. Thank you so much, Dr. Hare.
Thank you, everyone. Have a great day. Take care.
Thank you.